Welcome to the UNCG Entry-Level Masters in Athletic Training Education Program, Preceptor Initial Training. I want to thank you for agreeing to be a preceptor for our program. I am Aaron Terranova. I'm the clinical coordinator for the UNCG ATEP. This is the second of the 4 modules in the initial training to be a preceptor for UNCG. As a reminder, after the 4th module, there is a link to an online quiz you have to take to verify if you completed these 4 video modules, and we also schedule a face-to-face meeting to go over any questions and issues you may have. For those of you who have not watched Module 1, I encourage you to go back and watch Module 1 before proceeding to this module. This is Module 2, which is the ATEP at UNCG, and this is going to take us through not only our philosophy of athletic training education at UNCG, but also some of the nuts and bolts and administrative aspects of it. So we're going to begin with some key terms that we use not only at UNCG, but also at the national level through CATIE and through the NATA. And the first ones are ATEP and MSAT. Now the MSAT is the degree that our students will actually earn. So they earn a Master of Science in Athletic Training. We're going to use these two terms interchangeably. So if you hear ATEP, which is Athletic Training Education Program, or MSAT, they're the same thing. The other terms that we use at UNCG are clinical rotation objectives, or CROs, and for each rotation or each clinical assignment, there are specific rotation objectives that the student has to complete, and we'll get more into those as we continue through the modules. But if you hear that term, that's what we're referring to. It's just what the students need to complete during their rotation. Supervised autonomy is what we really feel the students need, and that's the ability to work independently with a preceptor, at the same time having the preceptor be able to supervise them and assess them so the safety of the patient is never compromised. Now, in terms of CATIE terms, the term preceptor replaces the old term of ACI, and it is a certified or licensed professional who teaches and evaluates students in a clinical setting using an actual patient base. If you remember from Module 1, preceptors can be really any credentialed medical professional, although the majority of the clinical experience needs to be an AT. Now, the supervision and the way that CATIE defines supervision is that the preceptor must be physically present and have the ability to intervene on behalf of the student and the patient. We talked about that in Module 1, but the intent of this is that although we want the student to have autonomy, to be able to think independently and to make clinical decisions, we need the preceptor there to protect not only the patient, but also protect the student. Now, this is a term which is not in the CATIE vocabulary, but it is something we talk about a lot at UNCG, and that's learning over time. And what it really is talking about is taking the formal instruction, internalizing, practicing that formal instruction from the classroom and the laboratory, and then putting it into the clinical setting where they're going to be reevaluated. So it takes time for this to happen. Also, what we want the students to remember is that this learning continues. So what they learn their first year, their first semester, they're going to build on that into their second semester and their third semester, their fourth semester, etc. So this learning keeps building, keeps increasing, keeps getting more and more sophisticated as the student progresses, not only through the formal instruction, but also through their clinical experiences. So what's your role in the whole thing as a preceptor is that your idea is that you're going to give instruction feedback and you're going to build on their past skills. So if you have a first year student, all their past skills are going to be from their undergraduate. But if you have a second year student, they have past skills from their undergraduate and their first year at UNCG. You can build on their past rotations or formal, etc. So really your role in learning over time is to build on what they have learned and give them a little bit more. Remediate them, give them new challenges, have them start to critically think, etc. So that's your role in how we help to develop the education here at UNCG. Now, sort of our overall philosophy, we go by the scores, which is stakeholders, CATIE, opportunistic, real world, enjoyable, and setting specific. And I'm going to briefly touch upon all of these. And the first one are stakeholders. This is a lovely photo of our old head athletic trainer and an old preceptor force and faculty force. And everyone has a stake in this program, from the preceptors to the faculty to the staff to the students to the alumni to the patients. Everybody has a stake in our program, and that's what we want to hear from you as stakeholders and what we can do to make this program better. So we want to have open and honest communication between everybody. The second is CATIE. Now the CATIE, if you remember from Module 1, they are they develop the standards for what we need when we deliver our program. They really are the skeleton of our athletic training education program here at UNCG. But the KD has allowed us enough flexibility that we can flesh out our program however we see fit. So think of KD as the skeleton, and our actual program as the flesh to meet the bone, the fleshed out of the actual skeleton. Now, we are opportunistic. We want students to take advantage of any opportunity. So if they have a chance to do a preseason screening that looks at measurements of hamstring extensibility, etc., we want them to take advantage of it. They can watch a surgery, take advantage of it. We want them to seek out these opportunities, and we want these opportunities to happen in the real world with real patients in real time with real injuries, and we want it to be enjoyable. I think sometimes people forget that clinical education should be a fun thing. When I was in school, the clinical part of it was the most fun part. I love that, getting in there, working with real patients, getting to know my athletes, etc. So let's not forget it should be fun, and it should be setting specific. In other words, what happens at the high school, they're not going to have the same clinical rotation objectives that someone working in a rehab intensive setting will have. Male populations might have different objectives than a female population, so we want to be very, very setting specific. So if you put all of this together, this is how we really sort of want to run our ATEP here at UNCG. Now, kind of how we break it down is that the faculty, they're in charge of the foundational knowledge, laboratory, simulated experiences. But the preceptors, if you remember from Module 1, I said you are where the rubber meets the road, and you really are. You are taking the clinical experiences, you are in charge of their rotation objectives, etc. But don't forget the students also have a big role in it, and they are responsible for communication. They're responsible for helping with peer-assisted learning, helping their fellow students get better, etc. So everybody in this slide has a huge amount of responsibility and a major stakeholder in our program as a whole. Real briefly, how we run our academic plan. It's a 2-year plan, 5 semesters, starting with their first summer, where they get foundations, which is taping, wrapping, crutch fitting, emergency care, that type of stuff, into anatomy. Then they have their injury assessment and modalities in their first fall, followed by their first clinical experience. That goes into FAIR-X or rehab with pathopharmacology, general medical conditions in their second clinical. So after their first full year of academic, they've had 2 clinical experiences plus a pretty good chunk of their foundational didactic knowledge that they're going to need, or their formal instruction. Their second summer, they don't have any formal courses, so they're encouraged to do internship, work camps, PBATs, NFL, whatever they can find, just to help broaden their clinical expertise after they've had all this formal instruction. And then they come into their second year of formal education, where they have their management administration, sports psych, optimizing athletic performance, which is basically trying to bridge the gap from the ATR to the field and talking a lot about strength and conditioning principles, etc. And then really they have their lightest formal education in their second spring, which is basically a BOC prep. They take a research methods in their last clinical experience. Obviously their second spring, they're worried about the BOC exam, they're trying to find a job, etc. So we don't overload them with formal instruction at this point. The philosophy of progression is really, really important, and what we want our students to be is, if you kind of remember Bloom's taxonomy, this is taking Bloom's taxonomy to a whole new level. We want our students, or especially our second year students, to be at this area of the progression. And we know that most of our first year students are going to kind of be down here. So if you look at a first year student, they're really good at factual information and remembering things. So it's what test to use to test for an ACL. Lockman's, boom. It's factual, they remember it, that's it. And as they develop through their formal education, through their clinical experiences, we want them to be more knowledgeable, and we want to be more processed on this continuum. So what you want to have is a second year student who has some metacognition and able to create. Now, metacognition is sort of a weird concept, but it's knowing that you're knowing, which I know might sound a little weird, but what it really means is that you are aware of your own knowledge. So what metacognition is, say, let's take an example. A student might say, I know I'm not as good in doing a shoulder post-surgical rehabilitation as I am doing a knee. They are aware of their own knowledge and their own learning, and what you want to see is bringing in the creation part of it, saying, I am not as strong in my shoulder rehab as I am as my knee rehab, so I need to make sure that I create a shoulder rehab plan prior to my patient coming in. That's sort of what we're looking for in our second year, second semester students, whereas our first year students are going to be down here in basic facts and remembering. So sort of keep this in mind as you're getting students and seeing where they are in their educational process. Just kind of keep this in mind. Now, each student will experience multiple settings, multiple patient populations, injury exposure, and this is going to be based on not only what the student needs, but also what you as a stakeholder needs. Some of our settings say we need a student, it helps us out, so we want to make sure we're taking care of you as a preceptor and taking care of you as your clinical site. And a lot of thought, time, and effort goes into how we assign students over their 4 rotations. So each student is going to be assigned at least one of these settings, one of these exposures, and one of these populations. And this might be a little weird to see, so I'm going to give you a couple examples. So the left column we have UNCG women's soccer, and then we have Northwest Guilford High School football. What you might see is that that's going to be a college university setting. That might be a lower extremity because you're going to have more lower extremity injuries. It's going to be a female sport because you're working with women's soccer. Whereas you look at the high school, obviously you're going to have a high school rotation, not a college rotation. We can make this upper extremity or lower extremity because football injuries basically go both ways, and we can make this equipment intensive, and it's going to be a male population. If you remember from Module 1, the Katie wants a variety of different exposures for our students. So after 2 rotations, you can see our students have a college, a high school, a lower and upper, a female, a male, and an equipment intensive rotations, and all of these have very specific clinical rotation of objectives, or CROs, that the student has to meet. This is just sort of an illustration of some of the various sites we have, and if your site is not listed here, I apologize. I only had so much room on my slide, but we have a variety of different levels of college. We have a variety of different high schools, rehabilitative intensive settings, etc. So just a quick little illustration of some of the sites that we use. Now, every student, we're looking for authentic clinical experiences. The length of the rotation typically is going to be a full semester or a full season. Our winter sports, like our basketballs, our wrestlings, etc., we can split them and we can do a couple of unique things to them. But for the most part, you're going to have your student for those full 15 weeks. We have a preseason at the start of their first year, and that preseason, because you can't simulate a real preseason 2-a-days, 3-a-days, so they will all have a preseason that first summer. And again, for Module 1, that's 300 hours per semester, about 20 hours a week, because we have a 15-week rotation and a cap of 500 hours. Again, these are Katie standards, and again, remember from the Katie, we have to have at least 1 day off per 7 days for each student. So that's Module 2, sort of the UNCG philosophy, some of our nuts and bolts, etc. If you have any questions, please feel free to re-watch this video. But as you go through, we have 2 more modules left, and we're going to talk about teaching and learning strategies, and then actually walking you through some of the administrative tasks here at UNCG.